Hey guys, as I stated before, I will be going over Hirschsprung disease with you. I found this condition to be very interesting, and I hope that you find it just as interesting as I did. So let's get started. What is Hirschsprung disease? Hirschsprung is also known as a megacolon or a congenital aganglionic megacolon. The aganglionic part is what really explains what the disease is caused by. Hirschsprung occurs within the first 12 weeks of gestation, so when you are forming in utero, for some reason there is a part of your colon where your nerves do not innervate or connect to the tissue. Due to the nerves not innervating, that specific part of the colon is unable to go through the natural peristalsis and is unable to properly expel feces out of the body. This part is also usually constricted and causes the feces to back up in the proximal part of the colon and causes abdominal distension, which in turn can be very life-threatening. The most accepted theory of the cause is a defect in the migration of neuroblasts where the ganglion are destroyed or unable to be produced, which causes them to be unable to properly innervate the tissue. It happens more frequently in males and also more frequently in patients that have Down syndrome. It's believed that the Down syndrome, which already has an effect on the genes, have an effect with the ganglion production. As discussed in the last slide, you can see here the part of the bowel that is not innervated by the nerves. The thin part, which is the aganglionic portion. That part does not experience peristalsis and constricts, which causes this thicker part above it. That is the distension in the colon. While it is most common in the sigmoid colon, it can occur in the other parts as well, which the higher up it is, the more life-threatening or more issues that will be caused by this disease. Now we're going to go through some of the clinical manifestations of this condition. Most of these will depend on the age of the patient. We'll have early observations, which are focused on newborns. We'll have the focus on infants and on toddlers as well. This disease is usually diagnosed within the first 24 to 48 hours of the patient's life, but can take up to 6 weeks or even later than that. The reason why it's diagnosed so early is due to the fact that the patient is unable to expel the meconium fluid that is present during birth. Early signs of this disease, there will be obvious swelling in the abdomen due to the buildup of the substance in the bowel. The patient will also have a pretty poor appetite. The patient will also have green vomiting, and the green tint is due to that meconium buildup. Or the patient will have explosive stools that will occur after a digital exam or digital penetration from the doctor, and it'll be very, very explosive diarrhea. Most of the older infant signs and symptoms will just be a build-off of the symptoms that were occurring as a newborn, with the same thing being true of older children. However, a big thing is the patient will be unable to really have functional bowel movements without an enema or suppository. So that becomes very frequent if the condition is left untreated. Here are a few good examples of children with Hirschsprungs. As you can see on the bottom left, that newborn does have a very distended abdomen. And on the right, we have a patient that just had a colostomy placed. This is a form of treatment, but that will be discussed later on. And as discussed earlier in the clinical manifestations, these are very similar to the nursing assessments that will be performed. You have your subjective and objective assessments with some things like being discomfort after eating, abdominal pain, irritability, decreased appetite. Those kind of things are more subjective, which most of that will be coming from your parents anyways, so they won't really know what's going on with the patient, even though they'll have an idea. You'll also have your objective ones. You can see the vomiting and the green tint to the vomiting, the weight loss, the increase in abdominal girth. Those things are your objective assessments. How is this disease diagnosed? Start out with the doctor will do an overall exam, which will commonly involve a rectal exam, which will cause the patient to have that explosive stool that we talked about earlier. The doctor will also listen for bowel sounds, which probably won't be present in the bottom left-hand side, left lower quadrant. With that happening, the doctor will order other tests, which will include a rectal biopsy, which is the best way to diagnose it, and that is viewing different samples under a microscope of healthy and unhealthy bowel. We also have x-rays performed, or also GI series that will use barium. This is easier to use and less invasive. And excuse me if I can't pronounce this, but there's also an anorectal manometry, which is a balloon that is inserted into the rectum. Normal children will have a relaxed rectal tone when that balloon is placed, but if it doesn't relax, that is an indicative sign of Hirschsprung's. This is a pretty good example of the X-ray imaging. And this is an example of the manometry, the inflating of the balloon. With this disease, surgery is probably going to be almost unavoidable. The surgeries will occur in two different stages. Stage 1 is the removal of the affected tissue and the placement of a colostomy. The main reason for this is to allow the colon to rest and allows the regular bowels to regain its tone. Stage 1 is practically guaranteed to happen, but if the bowel is too large, a colostomy will be permanent. Stage 2 is also known as a suave endorectal pull-through, and it usually is performed when the child reaches a weight of about 20 pounds. Basically, this is pulling the healthy bowel to the rectum to allow proper passage of stool. On this slide, we'll be discussing nursing interventions that can be performed. Our main focus are going to be preparing the patient for surgery and eventually colostomy care. Some interventions that these patients may need: dietary interventions. This patient should be on low fiber, high protein, high calorie diets, and in some severe cases, TPN may be needed. Patients may be unable to evacuate their bowels. This may require daily stool softeners or daily enemas. This will help decrease the size of their bowel and also make the pain more comfortable. Oral antibiotics are administered to decrease intestinal flora and to decrease the possibility of enterocolitis. Surgeons will usually set an NG tube to low intermittent suction during the surgery and order its removal as soon as peristalsis has returned. Patients will likely be unaware of any type of colostomy care and will need to be taught that or referred to somebody who will be able to do that for them. Patient teaching should be mainly focused around the parents. Parents should be taught how to adjust after the diagnosis, especially because this disease is affecting their newborn or their infant, and because this can be life-threatening. Be there to listen to them and available when needed. Prepare the patient for surgery and also prepare them for future colostomy care. Also prepare the parents for that. This should be discussed before surgery and on discharge as well. Also stress to the parents that the colostomy placement is probably going to be temporary, unless there is a large portion of the bowel that's affected, which will require a permanent colostomy. Post pull-through surgery, let the parent know that there could be some issues with diarrhea or constipation following that procedure. With that diarrhea, the babies may develop diaper rash, which is common. Toilet training might be delayed since the child is just now learning how to use those bottom muscles. They need to know that it could take a little bit longer for the patient to be able to completely control everything. Prognosis for this disease is very good. Approximately 90% of the patients that receive the surgery have satisfactory outcomes. The biggest issue usually is the diarrhea that can occur afterwards, which was discussed on the last slide. Approximately 1% of patients will have issues and will have to get a permanent colostomy following the surgery. In extreme cases or without treatment, sepsis can occur, life-threatening things can happen, which is why you need to be on the ball for this disease. Without treatment, there is a mortality rate as high as 80%. So this needs to be taken care of as soon as possible, and you need to be present on those assessments and be watchful for this potential disease which occurs in a lot of infants. Thank you.